Greetings from Indian Journal of Anaesthesia. I, Dr. Kiran Mahendru, will give you an overview of an article published in the June issue of IJA. It is a systematic review and meta-analysis on the effect of prophylactic corticosteroids on postoperative neurocognitive dysfunction in adult population. Postoperative neurocognitive dysfunction is common with an incidence of 11 to 51%. It can be seen in the form of either postoperative delirium, which is seen in the immediate postoperative period, and it is a neuropsychiatric syndrome with attention disturbance, disorientation to place and time, sleep deterioration, and memory impairment. Or it can be seen as delayed neurocognitive recovery, which is seen as a new cognitive impairment that develops up to 30 days after full recovery of consciousness from anesthesia. That is, when there has been offset of the pharmacological and physiological effects of the anesthetic agents. Now, there are various risk factors which can lead to postoperative neurocognitive dysfunction in a patient. It can be either increased age, history of neurological impairment, intraoperative blood loss, the type of surgery, presence of a urinary catheter, electrolyte imbalance, uncontrolled pain, use of opioids, and postoperative ICU admission. All these risk factors can lead to neurocognitive dysfunction, which can prolong the hospital stay of the patient, impair the activities of their daily living. There is a risk of delayed neurocognitive recovery, and this can have negative financial implications on the healthcare. The pathophysiology is basically inflammatory response caused by surgical trauma and blood-brain barrier disruption associated with the inflammation, which can cause injury to the brain. Therefore, the anti-inflammatory effects of corticosteroids have been utilized to attenuate the incidence and severity of postoperative neurocognitive dysfunction. This updated systematic review and meta-analysis of RCTs was done to evaluate the efficacy of different corticosteroids in preventing the postoperative neurocognitive dysfunction. The trial was registered with the International Prospective Register of Systematic Reviews. It is a systematic review and meta-analysis done on adult patients more than 18 years of age who underwent surgery under anesthesia. The intervention group was the patients who received corticosteroids during the perioperative period, whereas the comparator group was the group with patients who did not receive any corticosteroids. The primary outcome was the incidence of postoperative neurocognitive dysfunction within 1 month, as defined by the trial authors in their respective trials, whereas the secondary outcome was the severity of delirium, use of antipsychotic medications to treat postoperative neurocognitive dysfunction, postoperative infection, all-cause mortality, and hospital length of stay. It was done for a duration of 30 days postoperative period and was done in the perioperative setting. The data was included from PubMed, Embase, Scopus, and Cochrane Central Registers of Control Trial from inception to October 2022, with the mesh terms of cognitive dysfunction or delirium and corticosteroid or dexamethasone or methylprednisolone and postoperative period in various combinations. The eligible studies were reviewed RCTs that compared any corticosteroid with a placebo or no steroid in the perioperative period with the occurrence of postoperative neurocognitive dysfunction in patients getting anesthesia for surgery. The excluded studies were those done in the pediatric patients, animal populations, or non-randomized trials, or in the studies where comparison of two steroids or different doses of same steroids was done without any control arm. Treatment arms were clustered as active if different doses of steroids were compared with the non-active comparator. The trial extracted data of trial design, the publication year and country, number of patients, type of surgery, corticosteroid measured dose and outcomes, the type of control treatment given, mode of intraoperative anesthesia, incidence of delirium, the various scoring systems used for cognitive impairment, severity of delirium, need of antipsychotic medications, post-op infection, length of hospital stay, and mortality. The risk of bias was calculated using updated Cochrane risk of bias tool for randomized trials. The statistical analysis was done using comprehensive meta-analysis version 3.3. Weighted mean differences were used for continuous data and odds ratio was calculated for categorical data. The I-square statistic was done to indicate the trial heterogeneity and was completed for each outcome, and forest plots were generated to estimate the treatment effects. Subgroup analysis was done based on the type of postoperative neurocognitive dysfunction, which is either post-op delirium or delayed neurocognitive recovery, type of surgery, whether cardiac or non-cardiac, and the incidence of postoperative neurocognitive dysfunction. Due to limited pool data, subgroup analysis was not done for the dose and the type of corticosteroid used. Trial sequential analysis was performed for the primary outcome to ascertain whether the accumulated sample size was appropriately powered and to avoid any random error. Total of 15 RCTs with 15,398 patients was analyzed. The steroid group included 7,832 patients, and the control group included 7,566 patients. As per the risk of bias assessment, 2 of the studies deemed to be high risk for bias and 1 had some concerns. The funnel plot was symmetrical, therefore, there was unlikely that there was any publication bias. Coming to the forest plots for the primary outcome, the incidence of postoperative neurocognitive dysfunction was significantly lower in the steroid group as compared to the control group, thus favoring the use of steroids to prevent postoperative neurocognitive dysfunction. For the subgroup analysis for delirium versus delayed neurocognitive recovery, it was seen that the incidence of neurocognitive delirium was significantly lower in the corticosteroid group when compared to the control group, but there was no difference in the incidence of postoperative neurocognitive dysfunction, delayed neurocognitive recovery when steroid was compared with the control group. On the subgroup analysis for different type of surgeries, that is cardiac versus non-cardiac, there was no significant difference in the incidence of neurocognitive dysfunction for both the types of surgeries, whether steroid was used or not. Coming to the secondary outcomes, the postoperative use of antipsychotic medication, there was insignificant difference between the 2 groups. The severity of postoperative neurocognitive dysfunction, the scores were lower in the dexamethasone group. The hospital length of stay, there was significant difference with the use of steroids, but there was no increased risk of postoperative infection in the corticosteroid group. And also there was no significant difference in the all-cause 30-day mortality in between the 2 groups. Therefore, there is moderate certainty evidence which suggests that corticosteroids had statistically significant protective effect on postoperative neurocognitive dysfunction. The trial sequential analysis revealed that more RCTs are required to provide a more decisive answer regarding the effect of steroids on postoperative neurocognitive dysfunction. Subgroup analysis reported the prophylactic effect of steroids on delirium prevention is there, but it is not there for delayed neurocognitive recovery. The neurological complications after surgery are attributable to neuroinflammation. Therefore, corticosteroid given before or during the surgery can counter the detrimental effects of the inflammation. As this is a safe drug in single use and has multiple benefits in the perioperative period, the author suggests that effectiveness should be thoroughly explored before ruling out its role in prevention of neurocognitive dysfunction. It impacts the perioperative morbidity and mortality, especially in high-risk patient populations. And this neurocognitive dysfunction has multiple etiology, impacting not only just one pathway. Therefore, a bundled approach should be used where we should target multiple pathways of neurological injury in the perioperative period. And corticosteroids can be one of the components of this bundled approach. Cautious interpretation of conclusion should be done because of limited evidence and heterogeneity in the outcomes, such as the time and dose of dexamethasone given, the type of surgery, the different periods for assessment of neurocognitive dysfunction, the different definitions and evaluation tools for the same. There is lack of a standardized screening criteria for pre-op existence of any neurocognitive dysfunction. And most of the trials did not include patients who were at high risk of developing postoperative neurocognitive dysfunction. Therefore, this meta-analysis revealed statistically significant protective effects of use of corticosteroids on the incidence of postoperative neurocognitive dysfunction. The trial sequential analysis revealed that an adequate effect size was still not achieved. Therefore, further studies should be conducted to confirm the role of commonly used and a relatively safe drug in preventing this neurocognitive dysfunction. Further, RCTs should focus on bundle approaches targeting multiple pathways of neurological injury during the perioperative period and should target the high risk population. Thank you.